We're on now live. Go ahead. Okay, started. A very pleasant good evening to everyone. I welcome you to our South Caribbean Conference webinar on the COVID-19 vaccine. I am Victoria Dikoto, your Health Director and one of the facilitators on this program. As Seventh-day Adventists who look to the coming of Christ as the great culmination of history and an end of all disease, suffering, and death, we also recognize we have been entrusted with a health message that summarizes healthful living through practical and holistic healthy lifestyle behaviors. As a country, we have experienced our first COVID case of COVID-19 on March 12, 2020. And as of yesterday, we had a total of 137 deaths. It is our hope that this webinar today will answer your questions, allay your fears, and resolve some of the prevalent myths and rumors, thereby bringing peace of heart to our members as they are guided to make informed health decisions for their lives. I now welcome the other facilitator for this program, Dr. Oscar Noel Ocho.
Thank you so very much, Mrs. Dikoto, and welcome to our local, regional, and international community as we delve into a very important yet vexing issue that is affecting each one of us either directly or indirectly. It is our intention through this robust panel to deal with a number of issues surrounding the virus, surrounding the vaccination, surrounding the spirituality of all of this, and of course the myths. Do enjoy this experience, and we hope that with this panel of experts that have been drawn together, your questions will be answered and you would be better informed to respond to this issue of COVID-19 and the vaccination. My erstwhile colleague, Mrs. Dikoto, will take this opportunity to introduce our first panelist.
Great. Our first panelist will be Dr. Kern Tobias, President of the Caribbean Union Conference. He is the leader of our conferences and organizations across the English-speaking Caribbean, from the U.S. Virgin Islands in the north to Guyana in the south. And we are very privileged to have him this evening. Welcome, Dr. Tobias.
Joining Dr. Tobias is Dr. Zeno Marcel Charles, an adjunct associate professor of medicine at Loma University, and he has held faculty appointments at Andrews University, the University of Colorado, and Montemorelos University, where he was Dean of the Faculty of Health Sciences, School of Medicine and Allied Health Sciences from 2002 to 2012. He studied physics, physiology, zoology, as well as human medicine, and he is specialized in internal medicine as well as geriatric medicine. He holds a certificate in leadership from Mel and Enid Zuckerman College of Public Health at the University of Arizona. He is recognized as a past medical director of the Lifestyle Center of America, where he co-founded the first medical postgraduate fellowship program in lifestyle medicine in the US. He was the medical vice president of Wildwood Lifestyle Center and Hospital from 2012 to 2015. He is well experienced not only as an academic, but also as an administrator and author. And he works alongside his wife, 3 sons, and a daughter-in-law, by God's grace.
And now I present to you Pastor Leslie Moses, President of the South Caribbean Conference of Seventh-day Adventists. He is an experienced pastor, a family life educator, and has been serving as president for the past 5 years. Welcome, Pastor Moses.
Our panelist is also from the Americas. He is Dr. Michael Hogue, Dean of the Loma University School of Pharmacy and the current president of the American Pharmacists Association. Dr. Hogue is an expert in vaccines and immunization practice, and he currently serves as on the U.S. Center for Disease Control and Prevention Advisory Committee on Immunization Practice. Dr. Hogue.
And now we go to our Twin Island Republic. We welcome Dr. Tiffany Hoyte, the Acting County Medical Officer of Health for Tobago. She is a graduate of the University of the West Indies School of Medicine. She worked in the surgical department of the Eric Williams Medical Sciences Complex in Mount Hope, then went into public health in 2010. She then went on to do her master's degree in public health at Emory University in Atlanta, where she graduated in 2014. As the Acting County Medical Officer of Health in Tobago, she spearheads the public health response to COVID-19 in Tobago. She's also a member of the cabinet-appointed multi-sectoral committee to treat with COVID-19 and any other infectious disease. Welcome, Dr. Tiffany Hoyte.
And our final panelist is one of my erstwhile colleagues, Dr. Vishwanath Andy Partapsingh. He is a public health strategist and entrepreneur dedicated to strengthening health systems in the Caribbean sub-region with a focus on policy translation into action. He brings extensive experience in public health policy development and the translation of best practices into action at the local, regional, and global levels. And this is supported by 10 years of clinical experience, including hospital-based, intensive care, and community-based primary care. Dr. Partapsingh holds a master's in public health from Johns Hopkins University Bloomberg School of Public Health. His excellence while specializing in health systems and policy led him to being inducted into the Alpha chapter of the USA National Delta Omega Honorary Public Health Society. His passion for public health has also led him to being awarded with distinction as an Edmundo Granda Ugalde leader in international health. Dr. Partapsingh is currently a candidate in the Doctor of Public Health program at the London School of Hygiene and Tropical Medicine, my alma mater, to help public health organizations grow in the face of evidence-based best practices and politics around public health. He is also an alumnus of UWI St. Augustine, having graduated with the Doctor of Medicine in Family Medicine and Master of Science in Family Medicine, the postgraduate diploma in primary care and family medicine, and the Bachelor's of Medicine and Bachelor's of Surgery. What an erstwhile panel that we have this afternoon, Mrs. Decoto.
Thank you. So welcome to all our panelists. As we continue in our program, we would like to begin with our prayer by Dr. Tobias. After the prayer, we then will have each of our panelists give their introductory statement. Dr. Tobias?
Let's bow our heads and close our eyes for prayer. Our Heavenly Father, we thank you for your blessings upon us today. We praise you for who you are, God of love, mercy, compassion, God of wisdom, and even omniscience, omnipotence, omnipresence, eternity, and of course, immutable. So we give you glory for who you are, what you are continuing to do for us, your children. We plead your mercy and your grace upon the listening audience this afternoon, that we will understand the brokenness that this world allows because of sin and sickness that are pervading our environment. And so we come to you, O God, for wisdom. We come to you for understanding. We come to you for knowledge, and we're happy that you have equipped the peoples of the world in specialized areas of science and health and wellness, so that we can, and even theology, that we can be able to have a better understanding of where we are in the scheme of things and in the scope of time. And we can be prepared to even live healthier and happier lives as we await your return. Bless everyone this afternoon, we pray, in Jesus' wonderful name.
Amen.
Amen.
So the floor is now open for each of our panelists to give an introductory statement. We start with you, Dr. Tobias.
Well, I'm happy to greet everyone, especially the panelists, those who are locally and those who are internationally or related. We are happy to welcome you, and of course I greet the listening audience this afternoon. The Seventh-day Adventist Church is known for quite a few things. Amongst the things we are known for, though, is health and education, in addition to the preaching of the gospel. We consider our mission to be sharing the gospel of Christ throughout the entire world. And yet we are aware that we have to live in a real world that is plagued by sickness, sadness, and death. And so this COVID-19 pandemic has created a crisis of international and global proportions. And so this afternoon, I'm happy that the listening audience can benefit from the wisdom that God has provided through the Bible, through the sacred writings of the church, and of course through credible science research. And so it's a pleasure for me to be a part of this experience. I know that I'm here to do the prayer, and I have already done that. Whatever else I can say in relation to theology, I'll be happy to contribute, but I'm eager to learn from what the science will be teaching us this afternoon.
Amen.
I'm very delighted this afternoon to be a part of this panel. Of course, this panel discussion was the conceptualization of the professionals of the South Caribbean Conference, which I'm happy to be a part of. We thought we should do this today so that our members and the wider community can have an informed, informed opinions about COVID-19, the vaccine, because there are so many myths, there are so many conspiracy theories, there are so much false news, there is so much false news, fake news going about in regard to the vaccine. Some folk have major concerns. There's a major fear factor that pervades the international society in regard to the vaccinations. And of course, I need to acknowledge Mrs. Decoto and Dr. Ocho that Trinidad should have had Carnival this weekend. This is for overseas visitors. And we don't have Carnival this week into next week, but we have camp. Normally for Carnival, we would take our young people out to camp. This year we have virtual camp. So many of our young people are camping in tents at their homes, and many of them are looking on. So I want to welcome especially all of the campers from the virtual camp, locked down but not locked out. Welcome, campers.
Thank you. Dr. Marcel, Charles Marcel.
It's a privilege to be with you today. As you know, I'm a son of the soil.
Oh, yeah.
I was born in St. Clair, grew up in Belmont and in Mount Laud. That's beside the point, though, for today. Today, what we're dealing with is a global pandemic, an issue that has caused no end of suffering. And it seems as though things will go on and get worse before they get better. I would like to clearly state that some of the conspiracy theories and some of the myths that are going about have only added to the confusion and added to the suffering. Some people seem to pit God's word against true science, when in fact we need to all recognize that God is the God of true science. And he has given us the ability to think and to do and to be able to discover things about him through science that we would not have been able to do otherwise. The other issue is, of course, an issue of faith, and faith is based on evidence. So to think that blind faith is the way to go is also a myth. And the last thing I would like to say is that even though this pandemic has come as a surprise to some people, it should not be a surprise to Bible reading, Bible believing people, because if we say eschatologically that we're in the end times, then we should know that we will have pestilences, we'll have famines, we'll have wars, rumors of wars, etc. And what we need to do is to be prepared for these things and not be taken by surprise. So I hope that we're all today going to be able to participate, and maybe some minds will get changed as we discuss. Thank you very much.
Thank you. Dr. Hoyte, Dr. Tiffany Hoyte.
Hi, good afternoon, everyone. And let me just say thank you for the invitation to be part of this esteemed panel. So, throughout the world, we've had several pandemics, including multiple pandemics of the bubonic plague, cholera, the flu, etc. On March 11th last year, the WHO announced that COVID-19 was officially a pandemic after it had rapidly spread to 114 countries in just 3 months and infected over 118,000 people. A mere 9 months later, by December 2020, it had infected more than 75 million people and led to more than 1.6 million deaths worldwide. So the number of new cases is growing faster than ever, with more than 500,000 new cases reported each year on average. So yes, we've had pandemics in the past, but the ongoing COVID-19 pandemic is the first time ever in the history of the world that we would have had a disease ravage every single country, continent, or island throughout the world. And it's greater than just a health issue. For its crippled economies, it's affected every sector of our societies, from education to the tourism and airline industries to even how we worship. The COVID-19 pandemic has forced the world's population to become more resilient than ever. We've seen China construct a hospital not in 6 months or 6 weeks, but in 6 days. So this pandemic has forced the world to also become more technologically driven, with everything from international conferences, daily office meetings, even church services being held online. Necessity, as we know, as they say, is the mother of invention. And with such huge stakes at risk, this pandemic has induced greater collaboration and information and resource sharing between countries and industries, which has led to the use of new technologies to develop the vaccines at a faster rate than would have ever been accomplished in the past. So today we are at a crossroads in this pandemic, with several vaccines being developed in an attempt to curb the spread of COVID-19 throughout the world. We know many persons have queries and concerns surrounding the various COVID-19 vaccines. So I look forward to us discussing these today and other issues related to COVID-19. So thank you.
Thank you. We continue with a statement from Dr. Vishwanath Partapsingh.
Hi, good afternoon, everyone. Blessings to all. It is truly a pleasure to be part of this activity. I would prefer to be called Andy. There's no need to call me by my professional name or doctor. I'm this. We're all humans. We're all one. A friend of mine was talking about caring co-humans, and I think that's what this panel is about. It's about trying to bring together caring co-humans and take that message out and spread it. You know, I was listening to Dr. Ocho and the other speakers, and some real words popped out: sound and truthful information. What is sound and truthful information? You know, I ask myself that now. The real world, what is the real world? And when you look at it, the world has changed. Life has changed from when we woke up in January 2020. Life has changed a year, and we're not going back. You know, it's a new way. Industries, private sector, the way we consume, the way we purchase and interact with the world, that the investments that those sectors are making are long-term investments. So how do we as humans co-care? How do we as for each other? How do we as humans interact and grow and survive in this world that is new? And I know in preparing for this opening statement, some words came to me: survival, but then there's survival of the virus, because it's a thing, right? It's as Peter Pio was saying in one of his broadcasts, it's reason death is to live, to grow, to find a host. But then there's survival of us and thriving of us. And so where is the balance that we as human beings live and thrive in this world? And it comes down to a question of like selection, right? The survival of the fittest, and how do we make ourselves the fittest to survive in this changed and changing world. I am not in Trinidad. I came up to the US in November of last year because I wanted to be part of the global scene of it all, the biggest scene. And, you know, we talk about individuals and questions and member states and countries and communities. We all under one sky. We all under one group. And so we have to think about this force and this movement as us all, and not individuals and what this country is doing and that. It's what we as a whole, as a force, are doing. The last thing that I want, and I'm hoping that we get some conversation around and to explore, is the ethics of this. The ethics, I know for me, the end of last year left me with very much of an existential crisis on the ethics of public health practice that I saw and questioned, where is the God in this? Where is the God in the messaging? Where is the God in the voices? Or where's the spirit? If there are non-believers, but where is the spirit? What is the driving force? And the ethics of this all, the ethics of data, of how we meet, we share what we share with each other. And I think those are the big questions around that is really influencing moving forward, really influencing even uptake of the vaccine, or questioning the uptake of the vaccine, questioning the measures that we need to take, because vaccine yes or vaccine no, there's still measures of responsibility as caring co-humans that we have to engage in. And that's where my head is for this and the rest of the evening. So thank you so much for being part of this. I look forward to an amazing conversation about the future.
Thank you very much. And our last person, Dr. Hogue, will now do his opening statement for us.
Thank you very much. Can you hear me?
Yes, hearing you.
Good greetings to each of you in the name of our Lord from Loma University. It's an honor and a privilege to be with you today. I've thought about the comments that I would make as I start. My expertise is in the area of vaccines, and I currently serve on the United States Centers for Disease Control and Prevention's Advisory Committee on Immunization Practices COVID Vaccine Work Group. Each week, I review carefully the science behind the COVID vaccines and the safety of these vaccines, not only in the U.S., but globally. And so I will do my best today to share with you information that is based upon the science and the facts related to these vaccines. I'm reminded of the fact that the Lord tells us in his holy word that we're not to live a life of fear, but that we're to live a life of hope. And we're to live a life that relies on Jesus as our Savior and as our trusting Father. And I do believe very much that God gives us the ability to hope and to look hopeful. However, there's a world out there that doesn't view things the same way. And the internet is fraught with many people who would rather fill our lives with fear and create doubt that is not based in what God would have us to believe in terms of truth and fear. God is, as my brother said earlier, the person who gives us the ability to discover. God is in the science, and God helps us to discover things that improve our lives. And these vaccines are a great example of that. So I would just ask all of my brothers and sisters to not be gripped by fear, to not be consumed by social media and reports of things that are not true, but are instead designed to make us fearful, that are not based in the science, and to, in fact, to think carefully with the good brain that God has given us, to look carefully at the science and to be driven by that, and to be looking forward to the hope that Christ has given us. And today I hope we can address some of the many concerns that are out there about the vaccines. I hope that I can speak specifically. I know that from the Ministry of Health in Trinidad and Tobago particularly, that the AstraZeneca vaccine is the one that's going to be used primarily. And so I will share with you some science behind that vaccine. We will also share with you, as questions arise, about our experiences with the mRNA vaccines in the U.S. And we have a similar vaccine, not the AstraZeneca vaccine, but another one coming to market here in the U.S. Made by Janssen Pharmaceuticals. So we can talk about that as well. I look forward to responding to the questions and having a great dialogue this afternoon with my brothers and sisters here. And God bless you all.
Thank you very much. So now that we have all made our opening statements, Dr. Ocho, we turn over to you so we can begin our questions. Can you hear us, Dr. Ocho? Okay, so I believe he's having a little bit of internet problems. So we will go to our first question. For the listening and viewing public, you can put your questions. We will address them as part of the program. So the questions we have that came out so far, the coronavirus, it is not new. What makes this novel coronavirus? I throw it out to the panel. Anyone can answer.
Maybe I can start.
Thank you.
The coronavirus really is not new. We've had coronaviruses known and identified for many years. They're part of the kind of background virus population all around the world. What makes this one special is that it had a very specific way of being able to move from animals where it is common to infect in a jump, so to speak, to human beings. And this, with the ability to do that, is what makes this very special and makes it novel. And novel just means new. It's a new activity that this virus is able to do in the way that it is able to do this. Of course, we had other coronaviruses that would do something similar. That's the SARS virus, which will be like SARS-CoV-1, if you would put it that way, and the MERS virus, the Middle East virus. These are in the same kind of family, but this one, SARS-CoV-2, that is producing COVID-19, is a new strain, a new form of the virus.
Okay. All right. Dr. Ocho, you would like to continue?
Yes.
Questions?
Yes, so I'm glad that Dr. Charles started off with this. So could the panelists help us in understanding how does the body respond to this new virus or this new infection, which makes it not only different but more deadly than the other coronaviruses?
Well, I can give it a start, perhaps. So the coronavirus, probably by now all of you have seen cartoon graphics of the coronavirus, COVID-19. It is a circular virus and it has these spiky red components you've seen on the drawings that we use to illustrate it. And those spike proteins on the outside of the virus actually are the part that connects to human cells and infects those human cells very rapidly. And because our immune systems have never seen these kinds of coronaviruses before, our body does not have any sense of immunity or any sense of innate ability to fight off the coronavirus as a natural part of our immune system. Our human immune systems are very sophisticated, and we do recognize the virus as foreign. However, for reasons that we don't fully understand, the virus may in fact be more lethal and more deadly to some people than others based upon an individual's body composition. And that could be at the cellular level. because an individual has maybe a weakened immune system because of some other chronic underlying condition that they have, such as a lung disease, or they're taking some medication or use some medication that weakens their immune system naturally, or because we're just older. And as we get older, our immune systems are not as strong. And in fact, if you look at the number of people who've died from coronavirus worldwide, it's actually people over 65 and over 70 who tend to have the most terrible adverse outcomes from coronavirus. And we believe this is because as we age, our just can't respond to this new coronavirus that our body hasn't seen before. And so that is, on a very basic level, one of the reasons why this coronavirus is so lethal and is so difficult for our older people. One last thing I'll mention here, and I'll turn to my other panelists, but one last thing I'll mention. Many younger people actually don't get terribly sick from this virus. Many people, especially children, for example, don't tend to have very bad outcomes from this virus. Their immune systems are strong. They recognize the virus and they fight it off. And as we're younger, that's the normal path of our immune systems. But again, if we have chronic underlying disease or other things going on in our bodies, or as we age and our immune system's not as strong, it appears that we have a much harder time fighting off this infection.
Maybe,
Any other panelists?
yes, Dr. Hoyte, maybe I can sort of add to that. Again, one of the things that goes back to the first question about it being new, we're still learning how it is that the body responds to the virus, what really are the mechanisms, how does it get in, what really does it do? I mean, I've been looking at, I am by no means an immunologist or a virologist, but from my understanding, and the others can feel free to correct, chime in, clarify, there are these particular receptors, little bits of the linings in the nose, for example, that detect things that in the air that we inhale. And when those receptors, and maybe the audience would have heard about these ACE2 receptors, just to put it out there in case you've heard it. But some of the research tends to show that it is this sort of bit in our bodies, in the noses, that starts to detect the virus in the air that we breathe. And then when it detects the virus, we start to mount a response. Our bodies start to respond, start to fight back the infection. And for some people, we fight back that infection by producing antibodies in these chemicals in our body to fight back these viruses. But then for some people, we don't quite fight that well enough. And then the virus particles gets further down into our lungs. And then we start to set up where it goes down into the very, very tiny air sacs at the end, the end units of the lungs, the alveoli they are called. That is where oxygen transfer happens. The oxygen from the air that we breathe in to get into our blood. And that sac is literally one cell thin. And that one cell thin layer is very vulnerable to the virus. When it becomes vulnerable and becomes affected by the virus, it starts to break down. You start to set up inflammation. The fluid starts to accumulate, and you're setting up pneumonia. So, we hear a lot of these words, pneumonia, and we think scary and frightening. Not that they're not, but pneumonia is not a disease, right? It's something that we can find. It's a finding in the body. What is the cause of the pneumonia is what is the issue. And so COVID-19, the SARS-CoV-2 virus, can set up a pneumonia because that part of the body, the lungs, can be very vulnerable, very susceptible to the virus. But there are other parts of the body. Again, I was listening to a sort of session with Peter Pio, and he was talking about, he had the COVID-19. And, he was saying that it occurred to him that, we think about respiratory virus, But really and truly, anywhere in the body that has this bit, this ACE2 receptor, can potentially be affected by the virus. So, Oscar, I'm hoping that sort of adds some more light that there's a lot we don't know about how it happens. What we do know right now, based on what has happened so far, is this: the lungs are a big area for being infected. That's what sets up the pneumonia. And then you can have other parts of the body be infected. And maybe that is in part that explains why some people have different experiences with the virus. Some people have a mild experience. Some people have an experience where they need to go to hospital. Some people have an experience where they're in hospital and they need to go to the ICU. And then there is a real adverse outcome, which we don't want to say it. We don't want to say the word. Those who pass on, those who die, because their bodies become overwhelmed. So that's like a spectrum of how it affects the body, but a lot we still don't know, and we're still learning about it.
Dr. Partapsingh, I'm glad you raised the issue of the pneumonia, and maybe to invite you and the other panelists to speak a bit more, because one would recognize that this particular SARS-CoV-2 virus seems to have a greater affinity to the lung than the SARS coronavirus. And to talk a little bit of what the internists are speaking about the cytokine storm, so people could understand why the focus on the serious negative outcomes of this particular virus. Any of the panelists, including you, would like to speak a little more to this?
I'd be happy to. But I see we should go ladies first, I think.
Hi, so let me jump in. So, viruses, to add to what would have been said previously, so viruses work by getting inside the cells of your body, and then they hijack your cells to make copies of themselves. The virus, which causes COVID-19, that's the SARS-CoV-2 virus. It invades the surface. First infects the cells in the lining of your throat, your airways. It turns these cells into a corona, huge numbers of the new virus, which then go on to infect yet more cells in your body. So in the beginning, there's what we call an incubation period. That is the time between when you get infected with the virus and you first have symptoms appearing. So this is the time it takes from when the virus gets in for it to multiply and then to establish itself in your body. So, and that is usually average 2 to 14 days. Now, when your immune system recognizes that the virus has invaded your body, it produces the cytokines that you referred to, Dr. Ocho. And what these cytokines do, it rallies the immune system to start fighting off the virus. It gets the immune system ramped up, it leads to the production of antibodies, etc. But the cytokines also cause you to experience the body aches, the pain, and the fever. So when you start to get those symptoms, that's actually your body responding to starting to fight off the virus. Most people who are infected only experience mild symptoms like fever and body pains, which is the result of your immune system responding to the infection. About 14% of persons progress to severe disease, which will be due to your immune system now overreacting to the virus. So the cytokine chemicals, which are produced to rally your immune system, also signals the rest of the body to cause inflammation. But this needs to be delicately balanced. Otherwise, too much inflammation can cause collateral damage throughout the body. So in persons who progress to severe disease, they get inflammation of your lungs, leading to pneumonia. So as Dr. Partapsingh indicated, you have your tiny air sacs in the lungs, the alveoli. And when you have pneumonia, these air sacs become filled with fluid because of the inflammation. And that's why persons who have severe disease, they present with shortness of breath, difficulty breathing, and they may need to be put on a ventilator. And then you have a further subset of persons, most tending to be elderly persons or persons who have other diseases, or we say as comorbidities, where you have about 6% of persons become critically ill, where now you have multiple organs in the body start to fail, and this can result in death. And this critical illness and death is from your immune system again spiraling out of control with the amount of cytokines produced. And this causes damage throughout the body. So it can lead you to develop septic shock, which means that your blood pressure drops dangerously low and your organs stop working or they just completely fail. So your cytokines, which you produce to respond and because of the virus invading your body, can cause this widespread inflammation in the lungs so that you stop getting enough oxygen. It can also stop your kidneys from cleaning the blood. It can damage the lining of your intestines. So basically, the virus can set up a huge degree of inflammation that you succumb to because of multiple organ failure.
If I can unpack that just a little bit, think of it like this. If you had a problem in Port of Spain, and a military problem in Port of Spain, and the military decides to eradicate that problem, but they use big bombs, and these bombs not only damage Port of Spain, but all the way down to San Fernando, and all the way out to Toco, and all the way to down to Manzanilla. It's no longer the insurrection in Port of Spain that's causing the problem. It's actually the bombs that are being used against it that's causing the problem. So this infection is not just a single issue. At the beginning, it's one thing, but as it progresses, we have a different, what we call pathophysiology, a different mechanism for damage. And as you move along, these the processes may actually change. And as the panelists have said so far, not only is it something that affects the lungs, it can affect any of the organs that has ACE2 receptors there. And part of the mechanism for that, the underlying issue, is the oxidative stress issues that go on in our bodies because we are producing some of these damaging oxygen species that then cause damage to the tissues and not just the virus.
Oscar, I wanted Dr. Ocho, sorry, my apologies. You mind if I call you Oscar?
That's okay.
Good. So
Andy, that's fine.
Good. If you think about our context, right, especially the Trinidad and Tobago context, when you tell a patient or a relative of a patient, you say the word pneumonia, you get images conjured of severe, but not all pneumonia. The severity of a pneumonia differs, it varies, right? How it expresses itself. And I think, that's one of the things that in the new coronavirus, a new virus, a new word, there's going to be a lot of new that we are going to be hearing. A lot of new. And so responding to this new is going to be really, really, really interesting to us. How do we respond to new and coming back to what we know as the basics, and I guess that is part of the coping and the managing and fighting in this new phase, this new, and coming back to what does new mean? What does new mean in our context? That pneumonia is not new. It is the virus cause of it. So, helping us to sort of reel in the fear. One of the panelists spoke about fear. I think it was, I can't remember.
Dr. Hogue.
Yes, fear. And when we become fearful, it prevents us from actually thinking clearly, from relying on what we are returning to our support systems. And for much of the community, support system is our spiritual and religious belief, right? Or family belief. So I just wanted to add that there especially from our context. It is not that pneumonia needs to be feared, but that needs to be understood. and understand how your body is responding as or some or relative is responding who has been diagnosed with pneumonia due to COVID, or COVID pneumonia, or pneumonia due to the SARS-CoV-2 virus.
Okay, thanks so much. We got a lot. I wanted to bring the pastors in now, because but just before I bring the pastors in, Sister Vicky, I think I just want to ask one more question, if that's okay. Looking at, we are hearing a lot now about the UK strain, Brazilian strain, South African strain. What could the panelists tell us? Are these new viruses? What is this thing we're hearing about the strain? Because when we come to speak about the vaccine, this will have implications. But before we take the pastor, I just wanted to have this other question answered on the strains.
I think I can give you a brief description of this that I think will be very understandable. Viruses of all kinds have the ability to change or mutate or adapt to the environment that they're in. Sometimes they can do that in humans, and sometimes they do that mutation or change in animals. And I think the best way to understand how this happens with coronavirus is to actually talk about a different virus, and that's the influenza virus, the flu virus. All of us know that year after year, we have slightly different strains of the flu that circulate. And sometimes we have a very mild flu season, and the virus that's circulating is something that's familiar to our immune systems, or the vaccine has been created that works exceptionally well at preventing the strain of influenza that's circulating. And sometimes the virus has pretty radical changes in the way that it's composed. And so the infection that is circulating from one year to the next may be more severe. And the vaccine we have may not work as well at preventing influenza. So year by year, what happens with the influenza virus and the vaccine is that researchers try to modify the vaccine slightly from one year to the next to stay on top of the circulation of the flu virus. And this is why the flu vaccine changes, and we recommend an annual flu vaccine. Now, we don't know how rapidly coronavirus will change and mutate and modify. And we don't know if the modifications or mutations that occur with the coronavirus are substantial enough that the vaccine that we currently have will be effective or not effective. What we know so far is that the AstraZeneca vaccine appears in the UK to be effective at preventing the UK variant of the virus. However, we don't have enough information to tell us whether or not the vaccine is effective at preventing all the variants. We expect the virus will make some changes and modify itself. This is the normal way viruses change biologically. And so it is expected that over time, we will have to make changes to the vaccine or have booster shots or other things to be able to keep up and prevent this infection long term. Coronavirus is probably going to be with us for decades to come. It's the new thing, just like influenza stays with us and we have to stay on top of it. Coronavirus is probably something that we will be paying attention to. Hopefully, we will get enough immunity to coronaviruses through vaccination and through natural infection so that we do not have to hunker down, so to speak, and maintain this quarantine state for so long. But I do expect that there's going to be modifications and changes that will happen with the virus, and we as humans will have to adapt our defenses through vaccination and vaccination programs that will be long-term. Coronavirus vaccination programs will be long-term, and I expect them to probably be annual, just like our flu vaccination, for as long as we can imagine into the future. That's what my expectation is. Of course, I don't have a crystal ball. That's just an expectation based on virology. I'm interested in hearing what my fellow panelists may believe about the same.
I love this, so exciting, right? Because I've had to explain this to my family, and how do you explain this variant? And one of the ways that I sort of tried to understand it, and please panelists chime in, correct me, is that, remember when my opening, I talked about survival, right? And the reason behind viruses, their nature of being is to continue their growth, continue their evolution. So viruses keep fighting or keep working at surviving longer, living longer, spreading more. And in that process, they change. And in that change, these variants come up. I was looking at just listening, and the UK variant. Okay, the UK variant, because it was this new sequence, or this change in the virus, was found. It was first discovered in the UK, and so the UK variant, right? But they found the UK variant because there's a lot of testing that's happening. There's a lot of sequencing, looking at the genetic sequence of the virus. And so that's how you find a new variant, because you're testing, you're testing your samples for changes in their sequences, in their genetic makeup. And when you find a change that is different, or a sequence that is different, hence a variant. But some variants may not be stronger variants. They may not push through and then become the more dominant, the more prevalent, the more common form. And so that, I think, is for me where my sort of concern is, in this process of a virus changing as part of its nature to survive and becoming new in itself. How do these new variants in different parts of the world where they are found, how these new variants then translate to becoming so common that they now spread more, they become the more dominant, and then does that more dominant variant, is it susceptible to the vaccine that was developed for a previously dominant variant? We don't know. And as the previous panelist was talking about the effectiveness and the efficacy and the effectiveness, how well the vaccine stands up against these variants, that will come in time. And as we don't have the crystal ball, what does it mean? Does it mean that every season you have to get a new variant vaccine? Do you get booster shots of that will help you to build? Do you get vaccines that have different ways of fighting the different viruses, different variants? But again, the fear around a variant being attached to a location, the South African variant, as if we no longer want to interact with South Africans. The UK variant, as if we don't, I can't go to London, I need to go to school, right? I can't go to London because if I go to London, no one from the EU is allowed back unless you're a US citizen, and I'm not, right? So, and I can't come back to Trinidad because, if I were to go to London, because of the UK variant, maybe. So, we need to, again, coming back to understand that the terminology around the naming is not it should not be a basis for discrimination, for example, because again, it is a normal process of a virus trying to survive and live itself, trying to survive and thrive. We all do it. Humans do it. We vary ourselves to become more adaptable to our environments in the same way the viruses are doing that. And so it is the survival of the fittest. So, that's my way of understanding and trying to explain what variants are, how they mean, the naming around the variants. Sometimes, again, you would be probably in a clinic and you would hear a patient or someone talk about, well, I'm afraid of the South African variant. That one sounds really bad as opposed to the UK variant. And so, you set up a stage for separating ourselves from a common cause to fight because that is what we know. None of us wants to be isolated and quarantined, right? But we wouldn't fight it if we think or approach it from this very separatist view, being aware that this is a normal part of the process. And as the last panelist also said, this is for the long haul. This is not going away. Questions of eradicating the virus as opposed to living with and finding ways to manage. And Oscar, maybe over time in the panel we get a chance to talk about vaccine, yes, vaccine, no, but it doesn't preclude, it doesn't remove you from the basic measures that you need to keep taking to get back to live the life that, or to creating your new life. The basic measures of hygiene, covering your cough. I mean, they sound so simple, but staying at home when you're not well, when you have the flu-like symptoms. But these are time immemorial. They've been there long ago. So I just want to put that out there with the talk about the variants, because the new language, the new variants is also sensational, and it pulls away from the cause, the fight that we're trying to get at, which is we have a virus that we have never been exposed to. Its nature is to keep varying itself. We have to keep abreast of that fight. And one of the ways, and we have to find the ways of keeping abreast of that fight, and some of those ways are through vaccines. Some of those ways are through prevention measures. So yeah, that's my little bits, Oscar.
Yeah, maybe I can just add two little things. One is that the issue of variation is normal. This is the process, as you aptly stated. This is part of how the virus is going to do. The best case scenario involves two issues. If we have a variant that is highly infective, in other words, you get exposed and you'll get the disease, okay? But at the same time, the disease that you get is benign. This will be the best case scenario, because that will be like a natural vaccine, because that will be the primary circulating coronavirus variant that's out there, but it only causes mild disease in everybody, and that will be the best case scenario. We can only pray that this is what happens. Okay, it is more likely that the variant may have a different rate of infectivity, that is how prone it is to cause disease in someone who is exposed to it. And it may also vary in severity. That is, that if somebody were to get the disease, they're more likely to go on and progress to needing intensive care, and maybe even increased risk of death because of the virus. So that's a basic kind of situation there. The other thing I would like to point out is how the variants can work. And one way of thinking about it is if you had a detector of your fingerprint, okay, you can put your finger on a biodetector and it will read who you are. But the longer your nail grows, especially if it grows and curves forward, the more likely it will be that your finger will not be able to register as your finger, because it won't be touching the screen. In the same way, the vaccine that we have is against a particular signature. And so it is likely that we may end up with a variant that no longer looks exactly like the one before. Even though it's the same virus, it has some variation, such as the fingernails have grown longer, and we no longer can detect it the way we were doing it before, and we may no longer be able to protect against it the way we were able to protect before. And we have to make variations in the vaccine itself to be able to do that. So that's just a kind of way of looking at it in practical terms.
Oscar, do we have time for a little other comment on this, or do you want to? Because I don't know.
Well, if a judge gonna be half a minute.
So it is not going to be
fine.
half a minute. You know
because
me.
I think, Vicky, we want to get into the vaccine itself now.
Fair enough. Fair enough.
Yeah. We are hearing a lot about the virus, but people are asking about the vaccine. What is the vaccine? Approximately how long it takes to develop this vaccine, and also if a person gets the vaccine, can they still infect someone?
Those
So
are
what is the
those
vaccine?
are great questions.
What is the vaccine and how long it takes to develop a vaccine?
Could I start with this one, and then I'll let others go as well. But I want to speak specifically to the AstraZeneca vaccine because it's the one that is going to be used most frequently in your area. So I want to address that one first. Okay, a vaccine is a biologic product that is designed to stimulate the human immune system to produce antibodies. Antibodies are the cells within our bodies that fight off infection, anything that's foreign to us. And so we want to be able to stimulate antibodies without having to experience the actual infection. So we create vaccines as a way of providing our body with um, uh, a copy or a similar type of antigen or the type of thing that's going to potentially would have infected us and stimulate our immune system to produce antibodies so that when our body is in fact exposed to that virus, in this case, the coronavirus, our body produces antibodies and fights it off. So people have been concerned about this vaccine because they say, oh my goodness, this vaccine was created so rapidly, so fast. How is it possible that this vaccine is safe because it came so fast? Well, the truth is this vaccine, the AstraZeneca vaccine, is not new. The technology has actually been around for quite a long time. What is used is a adenovirus. It's a different type of virus, a cold virus. It's the virus that causes the common cold. And this virus is killed, and attached to this virus is the proteins that are specific to the coronavirus. And we've used this technology to create other vaccines for many, many years that we use to prevent things like rabies and other infections. And we know that this vaccine technology is effective at preventing other infections. So how is it that it was possible to get the Oxford AstraZeneca vaccine to market so quickly? Well, it's because it's old technology. And the only thing that was done differently here was the attachment of a protein from the coronavirus using old vaccine technology that we knew worked. And so if you do that, if you do that and you attach this, so the old technology being applied to a new virus really allowed us to move very quickly with vaccine development as it relates to the Oxford AstraZeneca vaccine. So that's how it came to market so quickly. The second thing that made the vaccine come to market so quickly was because World Health Organization authorities and governmental authorities, particularly in the UK and in the US and Australia, invested very heavily in vaccine production way before we had the final results of the studies on the effectiveness of the vaccine. That's never happened before in our history of vaccines because the governments invested to produce the vaccines quickly. We knew the technology was promising because we had experience with it before, so the governments were willing to actually pay to have the vaccines produced before the studies came back because we anticipated that we would get positive results. It was a good investment. It was a good decision to do that. By doing that, by having the vaccines produced even before the studies were finished, we were able to get the vaccine to market probably a year earlier than we would have had we had to wait on the studies to finish and then produce the vaccine. So it was really a good decision on the part of the World Health Organization and the governments in these nations to produce these vaccines early. But the AstraZeneca vaccine, please set your fears aside. While a coronavirus vaccine is new, the technology that was being used to produce the AstraZeneca vaccine is not at all new. It's something that we're very familiar with and that we've had familiarity with for quite a long period of time. Hopefully that gets us kicked off, and I'll let my colleagues on the panel expound further from their thoughts on this topic.
I just wanted, just before Andy comes in, Dr. Hogue, I want to engage you a bit on this. Could it be that the fact that governments and the international organizations would have invested heavily before the results, that we could be dealing with some ethical issues where the results were aligned to the expectations?
I hear you.
Because they took a 50% efficacy. What is the normal efficacy that they look for in the production of a vaccine?
This is great. And I think what I'll tell you is the U.S. experience, because it's the one I'm most familiar with. In the last 20 years in the United States, we have had quite a large number of vaccines for a lot of infectious diseases come to market, some to prevent childhood illnesses and some to prevent illnesses that occur primarily in adults. The United States Food and Drug Administration has a very strict process for the approval of vaccines, which requires that first dosing and safety studies be conducted to ensure the safety of vaccines and an appropriate dose. And then secondly, that enroll thousands of people into those studies and check to make sure that the vaccine is safe in a larger number of people and to make sure that the vaccine actually works. Efficacy for a vaccine varies. What's acceptable for the efficacy of a vaccine varies depending upon the infection that we're trying to prevent. Most public health officials in the U.S. would say that a vaccine is a good vaccine if it can prevent 1 out of every 2 cases of infection, or 50% of the infections that are out there. People would say a vaccine is fantastic if it produces 7 out of every 10 cases, or 70% of the infections that are out there. And we'd say that a vaccine is exceptional if it can protect or prevent 9 out of every 10 cases of vaccine that are out there. So in the last 20 years, the average study in the United States to enroll people and to examine the effectiveness of a vaccine, the average study in the U.S. has enrolled 26,000 people. The smallest study for a vaccine in the last 20 years enrolled 5,000 people. The largest one, 60,000 people. The average was 26,000 people. So just to give you some comparison, the Pfizer vaccine that's being used in the United States enrolled over 40,000 people. The Moderna vaccine, which is used in the U.S., enrolled over 35,000 people. The AstraZeneca study enrolled well over 35,000 people, and the study was done in multiple countries around the world, not just in one country or one nation. And I think that's also very important for us to realize. So the numbers of people who've been enrolled in these studies that we're looking at vaccine efficacy are very large, and they're ongoing, they're continuing on. The results were so positive with these vaccines that it would have been unethical to withhold the vaccine any longer from people, because in the studies, the AstraZeneca vaccine showed 70% effectiveness at preventing coronavirus infection. And the Moderna and the Pfizer vaccine showed 95% effectiveness at preventing infection, with no concerns about serious adverse events over the first 2 months of the study. So the Food and Drug Administration said, it's unethical to continue to withhold the vaccines. We're going to allow emergency use of these vaccines. We'll continue to study them. We'll continue to monitor the effectiveness. But if we know we have the chance of preventing 7 out of 10 or 9 out of 10 of every infection that occurs, it would be unethical to withhold the vaccine. So while I know that there may be concerns about governments and whether or not they rush things along, I've looked at the science of these carefully. I feel very confident that these studies are just as strong as the studies we've used to approve a whole host of vaccines over the last 20 years. And just today, in the Journal of the American Medical Association, the safety data for the Pfizer and the Moderna vaccine administered in over 15 million people total shows that the incidence of anaphylaxis, that's the most serious adverse reaction that could occur, has only occurred 2 times out of every 1 million doses given. That is a very, very small incidence of anaphylaxis and is approximately the same rate of anaphylaxis that we see with the influenza vaccine. So for what it's worth, Pastor, I believe what we're seeing here is good science. I believe the processes behind the scenes are good. But I think if you look at the evidence, you'll find that this is equally as rigorous as what we've gone through with other things in the past.
Other panelists?
Part of the issue is confidence. It's not just an issue of having good science in the layperson's mind. If they're not confident, they will find all kinds of reasons to say that this is not something that's good. So we have to recognize that this is part of the human condition. Okay, if we were to look at it from an evangelism standpoint, not everybody believes the truth that we preach, okay? Because they may not have confidence in what we're saying, all right? Some of the issue with confidence, at least in the United States, I mean, back in 1976, with the development of the swine flu under President Ford, this was a fiasco. And so that actually, still people refer to that kind of situation and say, you see, you can't trust these things, right? So that's on the one hand. And then in 2009, with the H1N1 vaccine, the rollout was problematic. And so people say, oh, I tell you, these things, people, governments and whatnot, you have to be careful what governments are saying. So these things have undermined it, if I would, people's confidence in things. However, it is not that the science is faulty. It's that some people, for whatever reason, capitalize on fear-mongering. They have an idea that this is bad, and therefore they would distort the truth. They would use some mixture of what is true and what is speculation and put that out there. And because we have a system of communication and information that goes so rapidly, in a short space of time, something that is not really good information, but actually disinformation or misinformation becomes part of the normal narrative, especially in people who have a lack of confidence, lack of faith. They don't understand the issues, and it's a mixture of truth and error, and they're led to not want to do something that is actually in their best interest, because they don't know how to be able to evaluate the risk, the real risk, and the real benefit. Okay, anytime we don't make a choice, we're making a choice. We're choosing to do nothing. And when people are looking at the problems with the vaccine, the potential problems with the vaccine, they need to put that against the potential problems of doing nothing and getting infected. And I think most people already know, they have friends or family members, or they know of somebody who has succumbed to this virus and the problems associated with it. And if you look at the short-term data with regard to the side effects of the vaccine, it's really, the vaccine is actually very safe, looking at it from the short term. Now, if somebody wants to say, well, but we don't have any long-term studies. I see in the chat somebody was saying we don't have any long-term studies. That's true. The only way we're going to get long-term studies is over time, where we're cataloging what happens with people who take the vaccine, and we don't have a crystal ball, right? We don't have clairvoyance to be able to say exactly what is going to happen. We have to have faith and confidence in the scientific approach and be vigilant so that if we see something happening, then we make the changes that are appropriate.
Such exciting conversation, right? Vaccination and clean water have been some of the most powerful public health advances, achievements. And we, society today, this is my perspective, right? I'm not bringing this, not asking anyone to adopt my perspective, but my perspective is that the world that we know today, society that we know today, is very much a function of vaccination campaigns, polio, measles, mumps, and rubella, right? Eradication of polio. And so we have that history that is in the context, in the background. But over time, we've evolved. Society has evolved. We've questioned a lot more. Data, persons, perspectives have become much more accessible, be they credible or not, be they evidence-based, peer-reviewed or not, be they anecdotes or not, but they're now accessible through multiple media platforms. Someone in Japan and someone in Trinidad can be seeing the same information at the same time, and so respond, and feel. And when you think about the data that we are responding to, or that people are responding to, it's within the context of, and I'm using data broadly, not just in terms of numbers, but stories, right? And narratives. And I love that word, narratives, right? Because that's what appeals to people, the stories that are told. Maybe it is because traditionally medicine and science presents what we found or what we find using numbers, and numbers are very difficult for a group to understand. Well, what do they mean? But then someone coming out and say, my child, my wife, a pregnant mother, brings a whole other different picture into being. And so that lights up a flame of interest, right? So, I mean, how do we package that data, that information that is of value, that the panelists are speaking of, that we need to be aware of to make informed choices? Oscar, I like to come back to my policy lens and my policy hat. And when you look at some of the work that was done around creating a new norm, right? Over time, maybe very, very, very slowly, the new norm to question the value of vaccine programs percolated through levels of our society, just filtered through. And we didn't know. The health sector didn't quite know that this was happening. And then when it was happening in a forum that we don't really interact. It was happening in social media. It was happening based on anecdotes and personal accounts. And so we weren't paying attention to this slowly creeping anti-vaccine drive or move. And again, this is my opinion, right? I'm not trying to impose upon, but just something to think about. So the COVID vaccine is now not just faced with a context that's naive to a vaccine, but is a context that's been primed to question vaccine. So how do you create a new norm? And when you come back to like some of the work by, these great researchers, I find great researchers in terms of looking at policy and how do you create new norms? Community cohesion is a very, 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 very important thing. Getting everyone rallied around one position. Can you find that in the world around the value of vaccines, much less the world around the value of the COVID vaccine? And when you have that degree of fragmentation or of segmentation, let's use segmentation. Fragmentation creates an imagery of just broken apart, but there's informed segmentation, whether it be informed based on science or not, right? So that when you have that degree of segmentation of thought, it becomes very difficult for the general, for my family to see what is going on and say, well, yeah, COVID vaccine, no COVID vaccine. And so packaging of that data, I think, is a big key. Oscar, you asked a question about whether, the ethics behind the involvements of politics and not just government level politics, but industry level politics, right? And how has that percolated through society expressing itself as, I don't want the vaccine? And when you look at products that are accepted by everyone, is how it's packaged, right? We need to package that differently. And looking at maybe taking those messages out, or and to the audience and the viewers, when you go to the supermarket or when you go to buy a replacement hose for your garden hose, you use a set of things to guide you as to how to choose the best hose, right? How to look for a credible brand, how to look for good quality. And you use that based on what is out there, right? You look at the way the package is made, you look at what the data it says, how the labels read. In the same way, when you're going out there to read up on the COVID vaccine, or you're hearing and interacting with stories on all the social media platforms about the adverse events or the favorable events, think about the package that it is coming in and go to the credible sources. I mean, Dr. Hodge spoke about the soundness, if I may use that word, of the data that is coming around out of the trials for the vaccines, speaking to the value of the vaccine. So go to the safe packages, go to the WHO, go to the CDC, go to your local Ministry of Health, for example, go to the New England Journal of Medicine. I mean, you may be surprised for the media out there. You may think that, well, I'm not a doctor. How do I read or access these sites? But when you go in and you will see patient information, you will find it in a form that you can understand. I think it's the JAMA, one of I have no allegiances to any of these journals, but if you look on the sort of YouTube channels, for example, you can find very simple conversations on the value of vaccines, exploring the differences among the vaccines, the different ones. Very simple conversations, but by brand packaging, by experts. And you can then use that. I ask, I think we need to ask our people, our members, our families, look for that packaging when you are getting your messages. I'm not saying to sort of close off and block out the stories and the social media posts. I'm not saying no, they are also valuable. But when you want to make an informed decision, just don't make that on one perspective alone. Go to those sites and you find them. Yep.
Great. I think, and you're speaking to the whole issue of health literacy. But before I go back to my fellow colleague, I think there are some issues coming out of what was said that I've seen in the chat where people are talking about. There is the conversation around, if I have severe allergies, should I take this vaccine? Issues around, if this is about my immune system, should I pay more attention to naturally boosting my immune system? And not taking the vaccine. One person said, my doctor said, they are no longer all this talk around likelihood of reinfection after the COVID vaccine.
I think I heard. I think I heard part of the question, Pastor. It seemed as though the audio was breaking up, and I'm not sure if that was my computer.
Oh,
But
are you hearing me now?
I can hear you
Yes.
now. I think
Good,
I got
good.
most of the. I think I got most of the question. I'll try to give you a quick response
Great.
on most of the issues. First of all, the challenge with whether or not people who've had allergies in the past should take the vaccine is certainly a decision that I think needs to be based on the type of allergy a person has had. These vaccines, the ones that are currently on the market, including the AstraZeneca vaccine, do not contain any preservatives. That's important for you to know. They contain the components that are required to evoke an immune response, and they're very simply formed. The mRNA vaccines contain things that are common in our food supply and in our medication supply currently. There's no substances that we're not familiar with in our bodies in terms of how these vaccines work. So the risk of allergy is pretty low, but it's not zero. And if you've had a serious anaphylactic reaction to a food or a drug, a medication, or a vaccine in the past, and what I mean by a serious anaphylactic reaction, I mean is if you took a vaccine or have eaten a food and you've stopped breathing and you've had to have medical care in order to reverse the effects of something you've eaten or a vaccine or a medication you've taken, then you would certainly need to be, if you decide to take the COVID vaccine, you would need to be monitored for a period of at least 30 minutes following the time that you received the vaccine. That's a very unusual effect, but that is the most serious effect that could happen, and it's the one we want to monitor. Let me speak for just a moment to a couple of the things that I think were in the chat that I think are important for us to talk about. The vaccine adverse event reporting system that's used in the US and then globally there are other monitoring systems are for reporting any event that happens following vaccination. Okay? If according to the US rules for reporting adverse events, if I get vaccinated today and this afternoon I have an automobile accident and I wind up in the hospital with a broken leg, according to the US vaccine studies data, that has to be reported. Okay? It's reported. Now, did that vaccine cause me to have an automobile accident and break my leg? No. People have automobile accidents and break their legs every day. If someone dies 2 weeks after they get a vaccine and they were 85 years old and they had underlying cardiovascular disease and diabetes, did the fact that they died 2 weeks later, was that the result of the vaccine? A lot of people who are 85 years old, whether they get the vaccine or not, and have cardiovascular disease and diabetes are going to die. Some people are going to live long lives and some people are going to die sooner. So just because it is reported that someone died as a result of us, reporting from a study, it doesn't mean it was caused by the vaccine. It doesn't mean that it wasn't caused by the vaccine. It just means that there has to be more research looking into it. So be very careful when you're looking at the information about, I saw on the news where this gentleman who was an essential worker received the vaccine and 2 days later he died. Okay, I think that's an important thing to note, but what else was going on with that gentleman? What were his underlying health conditions? Well, it was reported there were none. Well, most people's medical history is not reported publicly, and so we have to look at the circumstances around what happened to know whether or not it was related to the vaccine or it was not related to the vaccine. So I think it's very important to be measured about these things. It's good to ask questions. We want to be concerned. But so far, after about 40 million doses of COVID vaccines being given globally, there's not yet been a relationship, a causal relationship established that shows that the vaccine increases the rate of dying. In fact, there's a definite relationship that shows that the vaccine reduces the rate of death substantially because the vaccine prevents infection from COVID. And we know that people are dying at a daily rate that's alarming. Just in the US alone, we had just recently as many as 2,000 people a day dying from COVID. The vaccine prevents death. Okay, so is there a case that may result in death of a vaccine, one case in 40 million or something? I don't know. You know, the results are still out on that. But I can tell you the vaccine saves lives. And so, you know, people are concerned, I don't want to be first in line. I don't want to be the first person to get the vaccine. You won't be the first person to get the vaccine. 40 million people have already gone ahead of you. I've gone ahead of you. I've had 2 doses of the Pfizer vaccine. I had a very sore arm after both of them for the next day. For about 2 days after I got the vaccine, my arm was very sore, very similar to a tetanus shot. It was a very sore arm. My wife has received both doses of the vaccine. She's also a pharmacist. And the second dose of the vaccine, I just had a sore arm, and the second day I needed to take a nap. I needed to take a nap anyway, but I needed to take a nap on that particular day because I was pretty tired after I got the vaccine. My immune system was responding and it made me tired. My wife, on the second day after her second dose, she actually ran a fever of 100.9. She had body chills and body aches that lasted for 24 hours. She stayed in bed most of the day, and I learned to cook her supper that day. We made soup. Because I can open a can that had the soup. And so she got dinner in bed. She woke up the next morning. She was totally fine. She had no symptoms whatsoever on day 3 following the vaccination. I'm sharing this with you simply because I want you to know that I'm not just telling you about these vaccines to be telling you. I believe in them because I've taken this vaccine. My wife has taken this vaccine. My daughter, who is in health profession school in Birmingham, Alabama, she's taken this vaccine. We believe in it and we've taken it. And I can tell you from personal experience, our experiences. And I think that's the best thing I can do is to tell you my personal experiences.
One of the questions in the chat was, is the likelihood of reoccurrence after one has contracted COVID and has recovered, can you get it again and again?
Is that question for me or others? So reinfection with COVID has been rarely reported. It has been reported, but it's very rare and unusual for people to have a confirmed case of COVID a second time. I will say, however, to my fellow panelists' points earlier, as the virus does change and we have variants, we would expect that people would be able to have infection with coronavirus again from a different variant, but it would be quite unusual to have the exact same infection over again with the exact same strain of coronavirus.
I would echo what Dr. Hogue said. I would also add one other piece of information that came out last week, and that is that France has decided to go ahead, and people who have had confirmed coronavirus infection, they will receive only one injection of the vaccine, because they believe, because people who have been infected before have higher amounts of protective antibody in their blood, that only one injection would be able to boost them enough so that they'll be protected and they won't need to have 2 injections. So so there's more and more data coming out as to what happens with someone who has been infected before and how they will respond to the vaccine itself even.
I think also one of the, and that's a great point. I think part of the issue too is you've got to look carefully at the percent of the population that's already been infected. In France, it's an enormous number of their population. They've just been ravaged by COVID very early on, and large percent of their population had been infected. As by comparison, in the U.S., about 40 million people in the U.S. have had coronavirus infection out of a population of about 340 million. So we don't have quite as much population immunity that exists in the U.S. as the French people have experienced in their population. And so I do think that there may be some nation by nation strategies that exist as a result of what's actually occurred within the population.
Great. Another question that just came to me that for Dr. Hogue, can the vaccine change your DNA? And that's one of the questions, and they're saying, if I boost up my immune system with ginger and fruits and nuts, do I have to take the vaccine if I follow the health principles?
I've spoken a lot. I'm happy to speak on it, but I've said a lot, and I wonder if one of our other panelists wants to take the lead. I'm happy to talk about it, but I would certainly defer to my fellow panelists to have a chance to speak as well, because I've said a lot.
Similarly here, I would like to hear what some of the others might want to say.
You know, I've been reading the chat, and I find it absolutely fascinating. Very, no, because this is the real world, right? These are some of the thoughts in my head, in my family's mind. So and I'm happy that there is this conversation, because this is one of the first steps in coming to understanding what the new is for us. Airing out our thoughts and our feelings. So just on a side note, I'm just really, I'm happy to see the feedback that is coming through the chat. But to answer the question, to add to the thought about using complementary alternative medicine, traditional approaches. So I'm going to, answer that from two sides. As a clinician and as a public health practitioner, I will answer it from the perspective of what the data shows with regard to the use of alternative therapies and so. And what it says is that the evidence that surrounds the prevention measures that are of value to an individual or a family to prevent yourselves from getting the virus are social distancing, wearing your face masks, staying at home if you are ill. There is no sound or evidence to say that the ginger and the turmeric and these other measures won't help, nor will help. What has been shown to help are the measures of your social distancing, hand washing, wearing your face mask. What does that mean for you? What that means for me is I see no harm if it is I want to have ginger tea or boil a saffron root and have a saffron tea. But it doesn't mean that I'm going to do that alone. This is me. I'm not saying that others have to use that, but for me, it doesn't mean that I'm going to use that as my only source of protection and not listen to the other side, the other voice that says, well, still do these. So it is your decision. It has to be your decision, but make that decision by looking at what is out there. One way alone as opposed to two ways. For me, that sounds valuable. Having your ginger tea and your turmeric, but we don't live on ginger tea or turmeric tea or saffron tea, right? We live on other things too. So, I think it's an idea of, that's how I balance the two, so that's how I would answer that question. And that's because that's what I do. I think about how do I merge these two? I don't know what else, someone else, but that's my personal take. That's my personal practice. And yeah, that's where I sit on that in that position.
Thank you very
You know, the idea that living a healthy lifestyle is a panacea that essentially eliminates the chance of death is a myth within our community. People live and they die. This is how it is. Even people who were healed and resurrected by Jesus Christ, none of them are around today to tell us about it because they died afterwards. Okay, so we have to be clear on this. Living a healthy lifestyle is beneficial to our life in multiple ways, not just with coronavirus, in multiple ways. If your immune system is malfunctioning, then it behooves us to do whatever it takes for that immune system to work more optimally. Okay, so we should do that. But you know, we have some issues that are very fundamental with regard to immune function, and if we look at the underlying diseases that compromise our immune system and our immune system's response to the coronavirus, then we should be paying more attention, if you will, to taking care of some of those things. So if someone has diabetes and they're running high blood sugars, if they have not adopted a good lifestyle, if they're not doing the things that will help them to reverse, if possible, the diabetes type 2 that they have, then this is a good impetus to start working on this and getting that taken care of. Okay, but to say that in doing so you will never get the coronavirus, that would be that is not what we're saying. What we're saying is you live the healthiest lifestyle that you can for your total health, including coronavirus.
much. Thank you.
And don't assume that by doing this,
Could I
you
address?
will not become immune to the infection.
Yeah. Also, I hear the question, and what I am hearing in the question is the debate between prevention and cure.
Mhm.
That debate between prevention and cure, and whilst it is important that we make the statement for cure, and this afternoon it's more dealing with cure, or maybe preventing an adverse situation, an adverse health situation. I'm hearing the question saying, what can be said in favor of prevention as it relates to building the immune system, building up the immune system? As Seventh Adventists, we have accepted the Old Testament philosophy of health, which is prevention. What we eat, be careful what we eat, going back to the original plant-based diet. We have talked about New Start. That's a very popular acronym in the Adventist system. N for nutrition, E for exercise, W for water, S for sunshine, things like that we all know. A for air, R for rest, and T for trust in God. And then, of course, you have celebration and creation as other acronyms. So that I am hearing the question being asked, what is being said for prevention? And I know that many Seventh Adventists have not fully embraced the healthy lifestyle. The flesh is still a big issue, and doing stuff that the Bible does not countenance is still a big issue for many. So I'm just making the case for the balance for the listener, that you have to understand what Dr. Charles Marcel just said, and the other panelists have just said, that decisions that we make for health enhances the quality of life.
Yes.
And it allows for us a better chance to even benefit from whatever science is providing. I thought I wanted to add that component as well.
Thank you very much, Pastor. And if we look at a healthy lifestyle as a risk reduction strategy, then we would have placed this in perhaps the best context. To say that by doing things to intervene that we will not be also intervening with regard to diseases that we may have, including infections, would not be a true statement. But we don't have all of the scientific evidence to demonstrate this. But maybe, if we talk about, let's say, sunshine and sun exposure, well, we know that the sunshine actually provides us with enough vitamin D. And we know that there's an association between low levels of vitamin D in the blood and the death associated with COVID-19. Okay, this has been seen in several studies. It is an association. It is not a cause and effect, but it's easy enough. Okay, especially in Trinidad or in the Caribbean, to get enough sun exposure, and if that is not enough, to take a supplement of vitamin D. I mean, that's easy. That's easy stuff to do. Okay, fresh air. We know that being outdoors, and if you can't get outdoors, by having plants indoors to clean up the air, that also helps our immune system to function better. Drinking enough water, getting enough sleep. Okay, these are basic things. Okay, that we will do that decrease our oxidative stress and therefore improve our immune system's ability to deal with a plethora of different conditions, including infections. So I would say, if for the person who is on this panel, if you have not seriously thought about making lifestyle changes, I challenge you to make the lifestyle changes now. Okay, because this will help you in just about every aspect of life. And it's not just about doing physical things. It's also because our health is not just the physical things. It's our mental health, our spiritual health, our relationships, etc. Someone who is harboring unforgiveness and anger in their hearts actually are depressing their immune system. So I'm trying to make the case. Don't just think about the physical things. Think also about the mental, the relational, the social, environmental, and also the spiritual issues that produce a better life and a better functioning immune system.
Can I address the issue that my brother, I couldn't agree with you more, but I want to just quickly address the issue of the DNA, because that question, I think, has come up multiple times about whether or not the vaccine can alter the human DNA. And I want to just address that because I think I've told the elder and the pastor that I am unable to stay until the very end of the conference, and I apologize for that. So I want to address this scientific question, and then I may have to leave you, and I apologize for that. The AstraZeneca vaccine nor the mRNA vaccines have the capability of altering DNA, and I want to give you the reasons why. First of all, the mRNA vaccines, the products that are used in the U.S. from both Pfizer and from Moderna, are messenger RNA vaccines that once they are injected into the muscle of the arm, in the local cells around the muscle here, they are in the cytoplasm or the outer liquid portion of the cell. Your DNA is actually in the center of your cells of your body. They're not in the cytoplasm, it's in the center. And this messenger RNA vaccine actually stays in the cytoplasm. It doesn't go into the center of the cell. And there is a lipid layer or a fat layer that actually carries the messenger RNA into your cell, and then it dissolves very rapidly. And the messenger RNA replicates within the cytoplasm of your cell to produce the antibodies, then interact with your immune system and produce the antibodies. So the messenger RNA vaccine does not get into the part of your cell that produces DNA, and therefore it's not possible for this vaccine to change your DNA. With the AstraZeneca vaccine, the adenovirus that's being used to deliver the messenger RNA, they're both using messenger RNA to deliver that protein into your body, does go into the center of your cell where your DNA is. However, one of the important things to know is that in order to be able to change DNA or to produce DNA, you have to have something called a transcription. Well, it's sort of like when you write a note, you have to have a pencil to be able to write a note, okay? Without a pencil or a pen, you can't handwrite a note, can you? There's not a way to do that. You can't just look at it, and technology being what it is today, it's interesting. But you, in order to write a note, you have to have a pencil or a pen. That's a transcriber, okay? Well, the AstraZeneca vaccine doesn't have a pencil or a pen. So it has the protein that produces the antibodies, so it goes into the center of the cell, but it doesn't have a transcriber that can interact with your human DNA. So as a result of that, it also cannot alter your DNA because there's no way to transcribe the protein from the coronavirus into the human DNA. So neither of these vaccines have the ability to change human DNA or change the human genome. This is a myth that has been circulated on the internet by people who don't understand how the human body works and don't understand. And so in rather than trying to understand it, they've instead tried to spread fearful conspiracy theories on the internet, and it just isn't that case. So that's the science behind it, Pastor and Elder, and I wanted to make sure that I got that in there because there's so many questions that arise around this, and I just don't want to leave that unanswered. The last thing I want to say is this. I want to be very transparent with you all. I am actually Baptist and not Seventh-day Adventist. I was grateful to be invited here. I work at Loma Linda University. I absolutely love working at Loma Linda and understand clearly the Seventh-day Adventist teachings. I read Ellen G. White's works very deeply. Pastor Randy Roberts at the University Church at Loma Linda University is a dear friend of mine, one of the most powerful pastors. I love to hear him preach. I listen to him very frequently. We're brothers and sisters in Christ, ladies and gentlemen. I am your brother, and I believe very firmly in the teachings of the church. And I believe very firmly that we're here to continue the teaching and healing ministry of Jesus Christ. I believe that from what Pastor Roberts has taught me and what I've read from the North American division is that the church firmly supports vaccination and vaccines, and that there is no prohibition against such, that it's not contrary to living a healthy lifestyle to receive a vaccine, that the church is supportive, and that Ellen G. White, in fact, in her writings, was supportive of the use of vaccines. And so I'd ask my pastor friends that if I've mistaken on this, to accept my apologies and to correct me, because I would welcome the correction. But I believe that that's what I've been taught from Pastor Roberts and from the North American division, and I'm happy to receive that.
So let me just chip in at this point to indicate that Ellen G. White doesn't categorically make statements for or against taking vaccinations, but what we know based on her secretary's report, she indeed was vaccinated. So while she doesn't write anything concerning the vaccine or taking of vaccines, when there was an outbreak of smallpox where she lived at one point, she was vaccinated to prevent herself, and she encouraged her staff to be vaccinated as well.
Thank you for that clarification. I appreciate that, Pastor.
Sure.
So can I keep the theological discourse going?
And will you please forgive me for having to exit? I'm grateful to you, and I wish you blessings in the South Caribbean division of the church, and I pray God's blessing on you and your safety during this pandemic. Thank you for having me here, and I apologize that I'm unable to stay through the end of the service.
Thank you.
God bless.
Pleasure meeting you.
Thank you for being with us.
God bless you.
It's a pleasure. We can't thank you enough. So Pastors Moses and Dr. Tobias, there is a prevailing view among a lot of Christian groups that taking this vaccine is akin to the mark of the beast. What's your position on this?
Well, the Bible, clearly establishes the understanding of the mark of the beast. That is found in the book of Revelation, chapter 14, and we know that we are heavily involved in what we call eschatological understanding, because we go a long way in our church's history and theology in the books of Daniel and the Revelation, so that when we consider what the Bible says, if I were to read that portion of scripture in Revelation chapter 14, verses 9, from verse 9, it says, "And the third angel followed them, saying with a loud voice, If any man worship the beast and his image, and receive his mark in his forehead or in his hand, the same shall drink of the wine of the wrath of God, which is poured out without mixture into the cup of his indignation. And he shall be tormented with fire and brimstone in the presence of the holy angels and in the presence of the Lamb. And the smoke of their torment ascended up forever and ever. And they have no rest day or night who worship the beast and his image, and who receives the mark in his name, of his name. Here is the patience of the saints. Here are they who keep the commandments of God and the faith of Jesus." So that the Seventh-day Adventist Church hold the conviction that the end time controversy will center on the law of God, and particularly, the fourth commandment, so that the third angel's message will warn against the reception of the mark of the beast and will enlighten humankind as to the issues that are involved. And so for this reason, it should be made clear that Seventh-day Adventists understand the mark of the beast to be not a literal mark, but a sign of allegiance that identifies the bearer as loyal to the power represented by the beast. Of course, the church has its theological understanding as to what the beast is and what the image of the beast is, the old papal system, and we have been able to have our own interpretations of that, which is not the issue this afternoon. However, it should be noted that it is not a literal mark. People are saying that there is a chip something that will be put in the vaccine to be able to function as a mark. It is simply a sign of allegiance, and we know that is a future reality that is being developed right now. People are making the decisions to follow Christ or to deny Christ, to be obedient to God's law or to deny being obedient to God's law. And even members who are in the church sometimes have difficulty to accept and understand what God has clearly enunciated as important, to the Christian context. So that's a myth that the church cannot substantiate, and so the theological understanding is that it's really allegiance to a system that is contrary to God and to his commands. That's the introductory remark. Pastor Moses will continue it, I'm sure.
Yes. What I would say to add to Dr. Tobias' contribution there is that the whole matter of the vaccine being the mark of the beast, or the vaccine having some chip in it that would be used to identify you and to cause you to buy or to sell at some point in time, really doesn't emanate from Adventist theology. I observe that many Seventh-day Adventists have adopted this theology nonetheless. And it has to be made quite clear that as far as we are concerned, as far as our church is concerned, the mark of the beast has to do with our choice to stay on the side of Christ and keep the fourth commandment, or to shift from that perspective and observe another day of significance namely the first day of the week as the primary day for worship. It is clear that this is a conspiracy theory. It is not based on understanding nor the Bible's teaching on what the mark of the beast is. And I'm happy today for us to be able to speak to it categorically and to indicate that this has no foundation in Scripture, not a spirit of prophecy.
Okay. Dr. Ocho, there's a question that came in to Dr. Hoyte. Dr. Hoyte, they're asking in regard to babies, should a baby be vaccinated?
Hi, well, thanks for the question. So with the current vaccines that have been developed, they would have done clinical trials to determine the safety of the vaccines, but none of the vaccines have trials that involve anyone under the age of 18. So currently, none of the vaccine candidates will be offered to anyone under the age of 18 years. So children will not be vaccinated at this point in time, and no one under the age of 18 years.
Okay, thank you very much. You have cleared it up for the.
If I may add to Dr. Hoyte, and what Dr. Hoyte indicated, as part of the approach to testing vaccines, testing medicines, and other therapeutics, these trials usually start with adults, and this wasn't, so it's a function of practice as opposed to a sort of bias towards going just to adults and avoiding to involve the children. As Dr. Hoyte said, that at this point in time, the trial process begins with the adults. And soon they would be moving to involve other age groups. And when that evidence comes in, that data, I stand firm by science and the evidence, but I also stand firm by my belief in being part of a connected system that is emotional, spiritual, that is physical with the world, with the environment that is around me, with people that are around me. And within that context, I pull all of that together when I make my decisions. And very often, a very small part of that is my clinical background. It is just the connectedness to what my upbringing, what my value system, what I believe in. And why am I sharing this? I'm sharing this because maybe these are the kinds of questions that we need to ask within ourselves. That I ask within myself when I'm coming to an informed choice as a caring co-human, right? To my fellow family, my fellow group. How do I preserve myself and so preserve the interaction that I have with others in my group? And one of the ways of doing that is relying on multiple, on what feels. I'm very much an empath, Oscar. I think I've told you that I'm very much an empath, and for me, feel is not just an individual, singular feeling, me alone feeling. It's what I feel based on what I have come to know, what I've come to experience, what my parents and grandparents have brought into me, what I have seen, and what is constantly coming at me. And that doesn't provide anyone on the panel or listening in with an answer as to what do they do. But it provides you with a method for what do you do. So, and I'm, again, looking at the chat, when I was more than happy to be part of this panel, it was not to say yay vaccine or nay vaccine. It was to talk about the new world that we find ourselves in, the new physical world that we find ourselves in. And how do we as caring co-humans, how do we as spiritual persons, how do we as a community integrate and interact and help each other and serve each other in this new world? And that is where I am coming from bringing out to the group.
Go ahead, Dr. Ojo.
I just in the chat, I'll put two in one and another. One, this person said that he was admitted for COVID-19 and is currently suffering from lung problems. Would the vaccine help? And an addendum to that is, can a person with asthma take the vaccine? So those two questions are lumped together related to lung problems and the vaccine. But there is another question which speaks to the legal implications. Does a family have any recourse should in case there be negative side effects, including death? Is there a legal leg for the person to stand on?
Maybe I can address some of this, but I think our public official might be able to shed some more light on it, on what's going on in Trinidad and the region. But let me start off by saying this: the vaccine does not treat people who have COVID-19. So the person who is in the hospital who has a lung problem with COVID-19 will not be helped by the vaccine. The vaccine is not designed to do that, nor can it affect the course based on the data that we have. All right, so it's not a treatment. The second thing, if I recall correctly, had to do with what was the second part of that you put together, Elder?
The second part was if the person is asthmatic.
Oh, with asthma. Okay. Yes. There is no indication that someone who has asthma
can they take the vaccine?
Yes, is an increased risk of an untoward event taking the vaccine. So people with asthma can take the vaccine. However, as was pointed out earlier, if someone has a history of anaphylaxis, etc., then that person will need to be monitored for at least 30 minutes after taking the vaccine. And just to allay people's fears, the average time for an anaphylactic reaction is 7.5 minutes. So extending it to 30 minutes is just to be sure that somebody doesn't have something that goes unnoticed. But the average time to see a reaction would be about 7.5 minutes. Most anaphylactic reactions occur within the first few minutes of having taken a shot.
Yeah.
Okay. The third thing is about recourse. We say that prevention is better than cure, right? And that is true, especially when there is no cure. Okay. So part of the issue here is we have to take this thing in its context, that what we are trying to do, what the world is trying to do, what responsible people in the world are trying to do, is to decrease the burden of this disease in the population and allow things to get back to some modicum of being normal, some modicum of normalcy, right? The post-COVID kind of situation. So all of the testing that is being done prior to using the vaccine in individuals, and the testing that's being done in people who receive the vaccine, is to try to mitigate any kind of untoward reaction that someone will develop. Okay. Now, as we said before, several of us, we don't have a crystal ball and we can't predict. But what we do know so far, after so many millions of doses that have been already given, there is no evidence of any short-term side effect that is of detriment to people. There are associations, and as Dr. Hogue mentioned, association does not mean cause and effect. The largest group that has been studied so far was a group in Norway with over 30 people who had died. They were all over age 85, In Norway, per month, 400 people over the age 85 die. They keep meticulous data. So the fact that these individuals died, they looked at their whole data, and it was not more than 400 people that died for that month. And therefore, even though they are investigating, they don't believe that this was a cause and effect relationship. The individuals who died actually were people who they expected to have succumbed during that time period anyway. So that is not so. In Germany, there were 10 individuals who died. They did a similar kind of study. They did not find any relationship between those two. In the United States, there are people who develop what is called ITP, or idiopathic thrombocytopenia purpura. This is a rare hematologic disorder. 1 in 35,000 people in the United States develop this disorder spontaneously. There are about 50,000 people in the United States who have this disorder. So far, with the number of millions of doses that have already been given in the United States and around the world, they've cataloged about 32 people who have developed ITP, much lower than what you would have expected in 1 in 35,000. So again, even though these things are being investigated, so far, these are associations. It's not really related to cause and effect. Now, why am I talking about that in terms of recourse? There has been a statement circulating that the vaccine producing companies have been released of all liability related to untoward events associated with the vaccines. This is not necessarily true, and it depends on the jurisdiction as to where somebody is. And I don't know what the law is in Trinidad and Tobago. I'm unfamiliar with that, and maybe our official can talk about what the law says about this. So don't just believe just because somebody says this on the internet that it will actually be something that's effective for you where you are. It requires the jurisdiction under which this thing is being evaluated.
Dr. Hoyte, can I bring you in on this? Looking at the ethical legal implications?
Are we putting you on the spot, Dr.
Hoyte? So with respect to the first question, where the person referred to themselves as having lung disease, I'm assuming they're referring to themselves in the context of being a long hauler. So that's actually persons who've been infected with COVID-19. They're no longer testing positive for the virus. It's clear the system, but they continue to have symptoms for months and months. The thing is, and we call this category of persons long haulers. So the long haulers, though, mild disease also be long haulers, where months after they continue to get symptoms. They can be persons of any age, it could have had any severity of disease. So it's really nothing currently that has shown what is the reason for persons who are long haulers. So the cause for persons persisting in having symptoms, the reason for it has not been identified as yet. Research is ongoing. So to say that taking the vaccine may help you resolve your symptoms, I don't think that the research is out there yet. Again, they would have to study. Now, there is protocols where persons who had the infection naturally can receive the vaccine. Most of the times they would give it 6 months after infection. So I think as studies continue to be done, as the research continues to come about, then we will identify if persons who have these persisting symptoms, if they will benefit from getting a vaccine. But there's nothing in my reading that I've come across that says, yes, it's used to help long haulers. With respect to the person who's asthmatic, yes, first we remember you would hear a lot of advocacy going out for persons who have other chronic diseases, whether it be asthma, diabetes, hypertension, to get the vaccine. So it's not contraindicated for persons with asthma to get it. You're actually encouraged to get it. With respect to can persons take legal action, now I plead my ignorance of the law in that I can't state exactly if there's a law. But what I would discern is in press conferences that the Minister of Health would have had, he would have indicated for the persons, the elderly persons who live in homes for the aged, prior to them receiving the vaccine, family members will be asked to sign off something which removes all liability from the government for giving the vaccine. So I will discern that to say that no, there's nothing that prevents persons from taking legal action if there's an adverse reaction. So that's, I can't really say that I'm that uncritical.
Okay. I mean, we have 40 minutes left for this discussion, and we do have a few questions left in the chat that I hope we could get some succinct answers for. One of it is has there been a history where vaccines were produced, they were found to be effective, and afterwards they've had to pull it off the shelf?
Well, in the COVID situation, there was one vaccine being tested that showed efficacy, but it was pulled and has not proceeded to go to market simply because the individuals who were vaccinated and the animals that were vaccinated developed a false positive test to HIV. Because of this, that vaccine was eliminated from the running, if you will, for production for human use. You see, you don't want to have a vaccine that, while it might be effective in preventing one disease, actually gives you a false positive test of another disease, because then you don't know whether the person has this other disease or not. And so that has been pulled. I don't know specifically of any other vaccines that have been shown to be effective that have been pulled, but I do know of some situations in the past. For instance, a lot of people make a comparison between what's going on today and the 1918 Spanish flu pandemic. Let me point out that during the 1918 Spanish flu, there were no treatments available. As a matter of fact, the issue of viruses, nobody knew what a virus was back in those days. The groups of scientists that were working in the United States at the time developed a vaccine against Haemophilus influenza, thinking that this was a bacterial infection. They did not know about viruses. And of course, that vaccine, while it was useful for Haemophilus, it was completely devoid of use for the Spanish flu pandemic, because it was not the right organism. The next one that comes to mind is what happened in the 1970s with the swine flu. There was one case of somebody in the military who developed swine flu. The idea was that this was going to cause a great epidemic in the United States. President Ford made orders so that vaccines could be developed. The vaccines were developed, and it was a debacle because the swine flu never really materialized to the extent that it was expected to be. And so that vaccine and that whole program went defunct. Just a little anecdote as well. In my own life, I was one of the first 400 people to receive the Hepatavax vaccine as a frontline worker in intensive care units and whatnot against hepatitis B. This was before we knew about HIV/AIDS. And after we got the vaccine is when we discovered HIV/AIDS. And the prime material for developing the vaccine was taken out of individuals who were heroin addicts, who were homosexuals. Wow. Okay, so the same population that had a high risk of developing HIV was the population that was used to develop a vaccine against hepatitis B. For 2 years, I was monitored, and there was a certain amount of angst because you don't know whether they were able to get rid of this unknown agent that was causing HIV. Thank God, as it turns out, it was completely sterilized and it could not pass on the infection. But these are some of the risks that you take in taking any vaccine. But at the time, hepatitis B was a fatal disease. Today, you get hepatitis B and we have treatments for it, antiviral treatments that we can use. We have hepatitis C that we can treat today because we have antivirals that we can use. But in those days, you got hepatitis B, you got chronic hepatitis, you ended up with liver failure and you died. Okay, so to prevent hepatitis was a great breakthrough, and using the vaccine was some of what we ended up having to do. Okay, and this is some of the risk that frontline workers always take. The number of people who died of SARS, which not SARS-CoV-2, but SARS, and the avian flu viruses. These individuals were doctors and nurses that were taking care of people, not knowing that that they were becoming infected, and within a matter of days, the virus had infected people linked to particular airline flights, and it killed many people on the front lines in Toronto, Canada, who had been infected on the flight. They later on went to the hospital, and it was unknown what precautions needed to be taken for those people. So I saw in the chat that people were talking about frontline workers, and I want to say that whether Christian or not, or having any particular persuasion, people who are on the front line, by the necessity of the jobs that we do, we are exposed to things that we have no knowledge of, and we usually don't allow fear of those things to stop us from being able to treat people who are suffering, who are sick, who are dying. But we also are much more aware today of precautionary things that we can do to decrease the risk to ourselves, and of course the risk of our getting something in the hospital and then taking it home and infecting our family members who have nothing to do with this decision. Anyway, that's my take.
Pastor Moses and Pastor Moses and Dr. Tobias, somebody in the chat is saying, I just want to know the church's position and move on. That's all they're interested in. What's the church's position?
I'm going to read the position of the church. Of course, Dr. Charles Marcel is the Associate Director of Health Ministries at the General Conference. I'm sure he had some input in developing this position. So I'm going to read the position, say a word or two on it, and even though Dr. Charles Marcel has spoken extensively, since he would have had some input in developing this statement, I would suggest that he may add. It says, the Seventh-day Adventist Church places strong emphasis on health and well-being. In other words, we still maintain our health message and encourage persons to live healthy lives. The Adventist health emphasis is based on biblical revelation, the inspired writings of E.G. White, and on peer-reviewed scientific literature. As such, we encourage responsible immunization / vaccination and have no religious or faith-based reason not to encourage our adherents to responsibly participate in protective and preventative immunization programs. In other words, the church says, take the vaccine. There is no issue in terms, well, if you want to, I should add, because other parts of the statement talks about conscience and the GC not, forcing it upon persons. But if somebody wants to take the vaccine, certainly they can. The church actually says you should. If somebody feels I should not, and this is too risky or whatever, the church says that's up to you. The reasons, though, would not be because of any mark of the beast or eschatological issue in relation to end times. And that is what I would say to that question. I don't know if Dr. Marcel Charles Marcel would want to add, since he may have been part of the drafting of this statement.
Yes, I would just add the following. We keep tabs on what's going on, not just in the United States, but around the world, in what's happening with health policies, etc. Now, we can't keep up with everything, but we keep up with most of the things that are important. And from that standpoint, we can only make comments and recommendations based upon the current knowledge. So if tomorrow that information changes, then the church's position may change. But up until this point, there is no reason to make any change in that statement. What we look at is based on the best available information at the time. And I would hope that people understand that that is the responsible position to take. For individuals, the church is not the conscience of the people. Each individual, as Paul says, must be fully persuaded in his or her own mind. And to get good information, accurate information, is what needs to happen. We have put out a series of articles, not about the vaccines or anything telling people that they have to take it or not take it or anything like that, but some of the basic science behind it. The latest one has been in the February issue of Adventist Review, February 2021, and you can check it out either in print or online. It's page 67, talking about the mysterious mRNA, so that people can understand the basic science behind mRNA, and therefore not be dealing with this from a position of ignorance or fear, but rather dealing with it from a position of what the actuality is. We're told that we should educate, and that's what we're trying to do. Thank you.
Also, I would like to say that since this is the official position of the church, and it is not a theological mandate or an ecclesiastical order, it is information. And so the pulpit of the church is to be used to communicate the official position of the church. Any leader who has some persuasion based upon information that he or she may receive from YouTube or from whatever source, the pulpit of the church is not to be used to posit personal views, but simply to allow people to know what the church's official statement is, as Dr. Charles Marcel has indicated, that if there is new information, the church is very transparent and open on these issues. You know, folks are trying to make some of these theories moral. So you're right or wrong, you're going to heaven or hell based upon these issues. Yes, they have significant, far-reaching implications, but we have to understand that they are not doctrinal issues as it relates to science, but we simply realize that God is the one who gives the wisdom and inspires scientists to come up with solutions to the problems of health in the world. We are not living in a perfect world. And so we do the best we can, and we follow the guidance that God gives through the leadership he provides in his church.
May I add something, Oscar?
Sure, Andy.
In adding to concerns around the possible events post-vaccine, and who should get it and who shouldn't get it, and the recourse that is available, and so just to add some background to what happens behind the scenes, or what should be happening behind the scenes. If one chooses to avail of the COVID vaccine, that is a conversation happens with the healthcare provider of that person. It is not a blanket statement that all of this category, or all who have asthma, who don't have asthma, or who are elderly and not elderly, can or cannot. It's an individual conversation that still happens beyond your making a decision to proceed with being vaccinated. That conversation is what is grounded, or should be grounded in, that evidence, that peer-reviewed best practice that the pastors referred to, in terms of what does the literature, the science, and science, peer-reviewed evidence is science. Science isn't just two beakers and mixing liquids, right? It's how we go about doing things and making decisions. So that conversation, that discussion, and I don't want to say it's a consultation, a patient-doctor consultation. It is that conversation will help to illuminate whether any individual has any contraindications to being vaccinated, meaning any hints that they should not receive the vaccine. So that's one measure. And the second measure, you heard, we heard about where Dr. Hogue talked about the 30-minute or the period of time of observation upon receiving the vaccine. Those are measures to protect, to observe or to protect us recipients or whoever is a recipient of the vaccine in the post period upon getting the vaccine, to ensure that you don't have or to respond if one does develop any adverse reactions for whatever reason. And then beyond that, there are or should be surveillance where we observe, we follow up post receiving the vaccine on the development of any adverse or any signs or symptoms. A friend of mine living in London has a chronic illness, and she's my age, and she got her first dose of vaccine, and upon receiving the first dose of vaccine, she developed high fever and a high heart rate within the first day of getting the vaccine. But what she also had is she had access to a healthcare provider to put in her information, to explain how she was feeling, describe how she was feeling, and for them to intervene, to say, well, okay, well, here's what we do. So it's not like, it shouldn't be a system where you just get the shot and then you go. That's not how the system is supposed to be designed. So there are other measures that should be in place to help you through the process of being vaccinated. What that would look like in the context or in the setting where our persons attending this webinar are, I don't know, but those are the standards, the science, the peer-reviewed standards of what should be in place for a vaccine, for any vaccine. And that vaccine surveillance isn't COVID only. Vaccine surveillance happens for every single vaccine that is on our schedule that anyone would have received. So it is not unique, right? This is a well-established system that is managed by, and other countries come together where they pool that information. So it's not just one country alone that will be submitting or looking at and assessing whether anything is happening on the adverse side with persons who receive the vaccine. It's pooled from every country at a global level, so you have the benefit of the experience across, and that in part is a form of peer-reviewed. That in part is a form of science, because it is grounded in a systematic, consistent, reproducible approach across, so that what is reported in one place and reported in the same, called the same name, so it allows for comparability. I'm sharing that not again to sway yay or nay, but to inform or to share that there are systems behind the scenes that are designed to, and there's science and evidence behind the scenes that are designed to support those who avail of the measures such as vaccination, the health measures such as vaccination. I know that was a very long-winded, but I was trying to be very as truthful in my sharing of my understanding of that surveillance system to the people, and that's the best that we can do. And that's what I think we are here for, right? We're here to share our truth and our experience to those of us, because that is my truth. Like I will tell you, I began in my opening sentence talking about having an existential crisis, and that is really where I am at. And my existential crisis is around what is my place and what is my service.
I just want to put to link back to. So can I bring Dr. Hoyte in at this time to link back to some questions in the chat? In Trinidad and Tobago, the minister started talking about the Pfizer vaccine. And in the midst of that discussion, we started hearing about the AstraZeneca that the government is going to purchase. So what is the difference between these vaccines as it relates to composition? And do you think that there's a view that we Trinbagonians may be guinea pigs in getting a lower value vaccine in the AstraZeneca than the Pfizer?
Wow.
You have me, you have me smiling. Because, interestingly, I've had colleagues from Bahamas and from St. Lucia call because there's the same discussion actually going on throughout the region. Because it's the entire Caribbean region that's getting the AstraZeneca. And people have the opinion, it's because we are a developing country that we're getting that particular vaccine. So let me start with the whole process of acquiring the vaccines. Now, Minister of Health would have said from early on that Trinidad and Tobago had signed on to a program called the COVAX. Yes. So what that is several countries would have paid money upfront through the COVAX program, part of which involves FAPhA, WHO, as well as some other agencies. Would have paid money upfront to help towards the development of the vaccine. So that's one of the things that allowed vaccines to develop quickly, because governments gave money to help the development. Now, when we paid the money upfront, we didn't know which vaccine candidate we were going to get. We just knew we paid, and we would be ensured that we would be able to receive vaccines when the approval were given for the vaccines to be disseminated. Now, one of the first vaccines we would have heard about was Moderna, and then we would have heard of Pfizer, and we would have heard of AstraZeneca. And there are many, just to say, we're hearing a lot about Moderna, Pfizer, AstraZeneca, but there are a lot of vaccine candidates out there, right? There are some that's been used by China and Russia, etc., long before. So having paid into COVAX, then we had to wait to see not all the vaccines that are developed and approved for emergency use are under the COVAX program. Example, the Johnson & Johnson vaccine is not offered through COVAX. So of the candidates that are part of the COVAX program, one then had to wait to see which vaccine you will be which one would be given to you. So it's not so much of having a choice, it's what would be offered to you through COVAX. So people are looking at the fact that the Caribbean regions would have been given AstraZeneca and the developed countries got Pfizer. So what's the difference between the vaccines, first of all? One of the predominant differences is the effectiveness of the vaccines, the efficacy. So you would have heard it said that Pfizer is 95% effective. Moderna is not far behind at 94.25%, I think. And then AstraZeneca is 70% effective. So people are like, but we're getting the less effective vaccine. Now, this is true. We are getting the one that has a lower efficacy rate, but there are many reasons why this is, one of which is demand. There are not enough vaccines being produced by any company, whether it be Pfizer, Moderna, AstraZeneca, Johnson & Johnson, to be able to supply the demand that is currently ongoing worldwide. So there's a limited availability of vaccines. If one has been paying attention, even in the US, for persons now, the Moderna, the Pfizer, AstraZeneca, you require 2 doses. For persons in the US who would have been given the first dose of Pfizer, there was actually uproar at one point in time because they weren't sure that they would have enough to give the second dose to them. So that speaks to how limited the availability of the Pfizer is. So you have a vaccine, of course, Pfizer is part of the reason Pfizer is in the highest demand. And then we talk about cost, which is also a factor that contributes to which vaccine we would have been given. So AstraZeneca costs $5 per dose, not per vial, per dose. You have 10 doses in a vial, so that's $50 per vial. And it's 70% effective. Pfizer costs $50 per dose. So that's $500 per vial. Moderna, which is about as effective as Pfizer, is $47 per dose. So when you do the maths, if I am aiming to immunize as much of my population as possible to achieve herd immunity, we're living in economic times where we don't have forex coming in. We know that a lot of industries and sectors have been adversely affected, and economies, especially our Caribbean brothers, where they're dependent on tourism. So a lot of those economies don't have that much money. How are you going to go for the best one? That you're going for the Rolls Royce, or are you going to go for the one of it's a functioning car? It's your good old trusty Toyota. It's going to get you where you got to go, and you can get more people there. So you have to look at what we call equity. Now that's different from equality. So when you speak to health equity, you want to know, as a government, you want to do what profits the most people. So at the end of the day, and that's the other thing that the COVAX program would have weighed. If you look at the countries that got Pfizer, their control, they are fighting to get control of their outbreak. Their numbers, the numbers of hospitalizations, the number of new cases, the number of deaths, nothing compared to us in the Caribbean. We have a lot better control than those countries, just using the public health measures. So that if we add a vaccine that is 70% effective to our arsenal, that would get us where we want to go, which is population control of this pandemic, faster than even if they get the Pfizer. So you have to look at various factors. You're looking at availability. There's not enough Pfizer to give everybody Pfizer in the world, right? You're looking at cost. As a government, do you have the money? So imagine if, now, and this is actually a real scenario we are tangling with, because the government is not only using COVAX to get the vaccines. They're actually having one-on-one discussions with these companies. So they're having one-on-one discussions with Pfizer. They're having one-on-one with AstraZeneca to even buy more outside of what COVAX will give. And they're having one-on-one discussion with other drug companies. So imagine if we have 2 vaccines in the country. You have the Pfizer and you have the AstraZeneca. You then have to come up with a policy that fairly says who gets which one, because everybody wants Pfizer. So, these are dilemmas that governments are going to face. But at the end of the day, you want to just not be selfish. You have to look at the whole control worldwide, because even if we are, let's say we got Pfizer, we eliminated the outbreak of COVID-19 in Trinidad and Tobago. Then what? We still going to keep our borders closed to prevent persons bringing it. And you have to look at the fact that you don't want to just achieve control in your country, you want to achieve worldwide control, and you want to do what contributes to that. So countries that really don't have it under control, you want to give them the vaccine that has the higher efficacy to try and get them there. Whereas for those of us who are going along with getting there, the 70% effectiveness could very well be effective enough. So in terms of thinking that this was just because that's not it. Availability, cost, how well you are currently handling the outbreak as a country, those are the factors that would have weighed into which vaccine the COVAX facility would have assigned to a country. But having said that, it's not that we're limited to only vaccines from COVAX. There are other discussions ongoing and other brands of vaccines that may eventually be had.
Thank you very much, Dr. Hoyte. Very interesting. I am sorry, panelists, we have arrived at the time when you only have half a minute to round off. All right, so could Dr. Partapsingh, would you want to give your half a minute round off?
Sorry, I was on mute. I just really want to say it was a pleasure being part of this discussion, and I wish everyone blessings and to a wonderful future.
Thank you very much. Dr. Charles Marcel?
Yes, I too want to add my thanks for giving me an opportunity to share, and perhaps doing some follow-up, because we probably haven't been able to answer all of the questions and allay all the fears, but you know, to be able to have open forums where we can speak openly and be able to encourage the brethren to think clearly and not be tossed by every wind of rumor or whatever on the internet, but to think clearly, to prayerfully consider the choices that they have to make. I think some follow-up probably would be useful and prudent.
Thank you very much. Dr. Hoyte?
So let me also say thank you for allowing me to be part of this panel. The discussions were extremely interesting. And for persons who are still, you know, they're not convinced and they're still looking for answers as to what to do, I encourage persons to make sure that they read and they get accurate information from accurate, reliable sources, the public health agencies, etc. And for persons who are worried about the side effects of getting the vaccine, I think you also need to avail yourself of the side effects of getting COVID-19. So we would have heard of people who are long haulers who get it, and for months they continue to have symptoms. And you have to look and weigh benefits versus risks to help make your decision.
Thank you. Okay, Pastor Moses, you want to give us your closing statement?
My closing statement would be an appeal to my brothers and sisters. Some people are very strong on their convictions about vaccination, and especially the COVID-19 vaccine. And sometimes we are so strong on our convictions that we demonize individuals who choose to take it, or demonize persons who would want to disseminate information that might be different from their view. You know, the Bible talks to us about, by this shall all men know, John 13, that we are his disciples if we love one another. My view might be different from yours in this regard. That does not mean I would be disrespectful to you or castigate you, you know, as an adherent to false teachings because you have decided that you want to have this vaccine. Let's love each other. Let's be respectful toward each other. Let us agree to disagree. And as Dr. Marcel said, panelists, I suspect we will have to come back again. We will talk to you at some point about that possibility. Of course, we have overseas folk that are busy as we are here in Trinidad and Tobago, and we have to do some consultation to see whether we can do a part 2. But as the president of the conference, I'm just throwing it out there. Quite a number of questions were not answered. I understand there were a million questions on the YouTube channel, and we didn't get to 100 of them. So we have quite a bit more to deal with. And so Dr. Ocho, this is the Koto, we may have to come back and treat with some of these issues further. Thank you.
Thank you very much. Dr. Tobias, you have the privilege of giving your comments. Thank you very much.
Well, it is always said that education is power. To know and be informed is to be in a very good place, you know, to make an informed decision. The thing I enjoy about God is that he has given to everyone the power to choose. And he respects that choice, whether it eventuates to weal or woe. And so I am happy to have been a part of this panel. For me, it was indeed informative and inspiring. And I trust it was the same for the listeners in the platform. May God's blessings be upon us, and may we be protected and use his wisdom to make the best decision to guarantee our health, the health of our family, and community and country.
Thank you very much. To all our panelists and to my co-facilitator, thank you very much. It was a pleasure working with you all this evening. Because of time, we have to go straight to our closing prayer by Pastor Moses, our president.
Dear Lord, we thank you that we were able to spend this time today, quality time, talking about the COVID-19 and the COVID-19 vaccination. Thank you, Lord, for the information. I too have learned a lot listening to the responses as it relates to the vaccinations. I pray that you would help us to be further informed. Please guide us by your Spirit to make the best decisions for ourselves, and help us, dear God, to behave as Jesus behaved and to treat every situation as Jesus would. Please help us as a church, help our members to be better off in terms of being more informed about life and the issues of life. We thank you for the spiritual input that helps us in our direction and our choices, our life choices. Please bless the panelists, grant them good success in their various areas of work and family experiences. We are happy, Lord, for the many, many viewers who are on the platform looking on, and we pray your blessings upon them as well. Some indicated that they had COVID-19, and we thank you, Lord, that they recovered. Please continue to help us to live wisely and to make the right choices in regard to the COVID-19 protocols and guidelines, so that we may protect ourselves. Help us to live right, to live healthily. Help us to adopt better health practices so that we can have a better chance of fighting off infections and diseases. So, Lord, we commit it all to you, and we thank you for the time we spent. Bless the campers who will go back to their camping experience this evening. Those children who joined us, I pray that you would give them encouragement, even though they may have had stuff today that troubled their minds. Please encourage them and keep them focused on the way that we have called them to go. And may we have a wonderful evening and a great week ahead. In the name of Jesus Christ, our Lord, we pray. Amen and amen.
Amen, amen.
Amen.
Thank you very much.
Blessings.
Thank you very much. God's blessings upon all of us.